of this. There are a bunch of different reviews that we've used in the past. I'm not going to take those down. This is something I put together. Hopefully it'll be better, but it's just kind of questions and something like starting to get you thinking more as to like, you know, what type of questions I may ask. I don't ask a lot of first order questions, right? So that's like the one-liners. If it's this, then it's whatever. I want you guys to think. You guys are seniors. I'm trying to get you ready for the pants, right? And they're not gonna normally ask a lot of first order questions. So a lot of these are first order questions, but these will get you kind of hopefully into that mindset of, if I'm gonna potentially ask about this, then what are other questions I can ask, like coming off of this? Yeah.
Just to clarify, this review will be posted on campus?
I haven't decided yet.
Okay.
Okay. I haven't decided yet, because I still have all the other reviews that I will probably keep them posted. I haven't really decided yet, because these are a lot of straight from your slides. So let's get into it. So question 1. Think about, what are the 6 major predictors of major cardiac complications according to the revised cardiac risk index? What are the 6? Not old age. I'll give you a hint. The first one is high risk surgery. What's that? Yep, preoperative treatment with insulin. Serum creatinine greater than what? 2. Cerebrovascular disease, yep.
Ischemic heart disease.
Ischemic heart disease, the last one. Nope, I said that one. Congestive heart failure, yes. So what are other 2 risk factors that we think about, but we don't necessarily talk about in terms of like this actual risk index? Hypertension and hyperlipidemia. Good. Okay. So those are the 4, or the 6. Okay. Okay. According to the ASA classification, how would you classify a patient with severe systemic disease that is a constant threat to life? I'm hearing 4. I'm Steve 5. 4. Good. It is 4. Okay. All right. A patient with chronic steroid therapy for lupus is scheduled for major abdominal surgery. What is the primary endocrine concern? And then what is that management strategy? What are we trying to avoid? Steroid crisis. Okay. Primary. What is the actual medical term of steroid crisis? Yep. Addisonian crisis and adrenal insufficiency. So how do we fix that? What do we do before surgery? We give them a what type of dose? Stress dose. Very good. Okay, so that's a stress dose of steroids perioperatively. Okay, and then we try to taper back post-op. Okay, what are the ASA guidelines for preoperative fasting for clears, lights, and then fatty meals? 268. Yep, 268. Good. What is the Mallampati score used to assess, and what does this class 4 mean? Okay. So you say class 4 is bad, but what does that mean?
All you see is orange palate.
Yes, you don't see any of your like oropharynx, right? You only see the hard palate and then the tongue. Like they cannot open wide enough so you can see the uvula. You can't see anything back there. Yep. So that is the airway. Predicts the ease of ET intubation. Good. Okay. What's the difference between a clean and a clean contaminated surgical wound?
What's the What's the difference between the Mellon-Potty score and the lemon criteria?
So the Mellon-Potty score is part of the lemon,
Right.
okay? The lemon is basically a more in-depth at like looking at the different, is it just a different way or another way in addition to the Mellon-Potty score to make it really a more in-depth at looking at how easy it will be to intubate? Okay, clean versus clean contaminated. Okay. Yep, respiratory, skin, and GU. Is there any feculent, any succus, any of that in any of these? What type of skin surgical wound would that be? If you have frank, dirty, right? Yeah. Okay. Good. What are the three components of a proper informed consent? Okay, I heard risks, benefits, and alternatives. Why is that important? Yeah, you have to be informed, right? You have to know what the good things are, what the bad things are, and then what is this the only way forward? Okay. And then what else do you need with an informed consent? Mostly written. There's sometimes we can do verbal. Need to sign it. Talk louder. I think you're saying something. Yep, so witness, patient, and provider. Okay, what if the patient is unconscious and cannot sign for themselves? Two doctors, right? Or if they have a family member who is their next of kin, which that is a whole nother lecture, okay? When you're talking to them about informed consent, what do you need to make sure they do? Understand it, right? If you talk in medical terms that they don't understand, if you say pancreatitis, do you think they really know what that is? Probably not. Okay, good. Patient has a serum sodium of 122. What's the condition called? And how rapidly why is rapid correction dangerous? Hyponatremia. Demyelination. Yep. Okay, so severe hyponatremia has that osmotic demyelination. Typically want to reverse it slowly. Okay. When is the one time that we use 3% hypertonics? Head injuries? In terms of hyponatremia? Nope. They have to be doing something. Seizing. If they are actively seizing and they have a severe low hyponatremia and they are seizing, then you give them a bolus, a small bolus of 3%. Those are the only two indications in which we give a hypertonic solution. Okay? All right. What is the first line treatment of a patient who has severe life-threatening hyperkalemia with EKG changes? Calcium. Good. Then what do you do? Insulin with? You can't just give insulin. You don't give potassium if potassium's high. You're on the right track. Glucose, it's just dextrose, right? An amp of D50, right? So you give an amp of D50 insulin, regular fast-acting insulin after the calcium. Good. You can use albuterol, but that's like a third-line agent. All right. In trauma patients who have hemorrhagic shock, what is the preferred fluid resuscitation strategy according to the massive transfusion protocol? What do we want to use first off? Whole blood or just blood, right? Blood in or blood out, blood in. And then what makes it a massive transfusion protocol? After 6 units, yep, we consider it. If we already know that this guy is like class 4 hemorrhage and he's still bleeding out in front of us, we're gonna call it even before we get to 6 because then we're gonna make sure that we just keep it coming until we turn it off. Okay? If you're not using whole blood, what's the golden ratio? 1 to 1 to 1, good. Okay, gold standard, that low titer O whole blood. Good, what's the purpose of an art line? Monitor pressures, blood pressures, invasive monitoring of the blood pressure, right? What else do we use an A-line for? An ABG, or like, are you gonna put an art line in if you want one ABG? No, multiple, right? If you're someone in the critical care setting and you, or even in the ER, and you have somebody on a vent and you're constantly changing that vent, and you have to poke them multiple times, then put in an A-line. Okay. What should you never do with it? Don't instill anything in it, right? It is only an out port, never an in port. Good. How do you calculate daily maintenance fluids requirement for a 70 kilogram patient using the standard weight-based formula? What is that formula? Yep, 30 mils per kg per hour. Okay, so if you have a 70 kilogram patient, what is the rate per hour? What do you think? You are allowed a calculator tomorrow. Or not tomorrow, Friday. Friday. Because I probably will not let you use your phone. 88 mils per hour. For a 70 kilogram person, 88. Okay? Alright, what's the difference between isotonic, hypertonic, and hypertonic IV solutions? Let's talk about isotonic. What does it do? Nothing, right? Good. What about hypotonic? Right? Pulls that fluid into that cell, so the cell is going to swell, right? And then hyper, got to pull out, so the cell is going to shrink, which is why we do it for the brain, right? We want to decrease. Okay, good. All right. And a postoperative patient who has low urine output, so oliguria, tachycardia and hypotension, and the fractional excretion of sodium is less than 1. Pre-renal, what's the most likely cause? Hypovolemia, we caused it, right? What if it's greater than 2? Intrinsic or post, right? If it's greater than 2 or 3, most likely you have an obstructive type process. Okay. All right. What's the difference between guarding and rigidity in an abdominal exam? Why is it important? Okay, so guarding is more voluntary, right? They're normally soft and jiggly, but as soon as you touch them, they guard, they kind of, move away from you. Rigidity is they're already guarding, they're already involuntarily contracting those muscles. Okay? So when you're rigid, when they have a rigid belly, it's already involuntarily guarding. Okay, it's a reflex versus a conscious thing. Okay? Alright. Which one are you going to have more so with a heel tap? A positive heel tap. So if involuntary guarding or rigidity is a sign of peritonitis, will you have a positive heel tap? Yes. If you have a voluntary guarding, are you gonna? Possibly, maybe, but not most likely. Okay? If they're voluntarily guarding, they're in pain, it could be a positive heel tap, but more likely not. So it depends on their pain. Okay? Alright. Patient presents with sudden severe epigastric pain. An upright chest X reveals air under the diaphragm. What's the most likely diagnosis? It's a perf, but of what? Something, right? Especially if they have severe epigastric pain, most likely they have a perfed ulcer. Perfed ulcer. Okay. Something in the hollow viscus is perforated. If it's epigastric, it's most likely an ulcer. If it's on the right side, right? If their pain was on the right lower side, maybe the appendix. If it's on the left side, maybe severe diverticulitis. Okay, it really just depends. Okay. All right. What are the classic signs and symptoms of small bowel obstruction? What are you looking for? Nausea, vomiting?
Distension.
What type of pain? Focal, colicky, absolutely. Crampy. What else? Obstipation, yeah. What's the definition of obstipation again?
Nobody comes out, gas.
Right. Inability to pass gas or stool. And then one more thing. You can see with, this is just with signs and symptoms. What is the belly gonna look like? Distended, right? What is the, if you were to do a percussion on it, would it be tympanic or dull? Most likely tympanic. Okay. All right, what are the classic signs and symptoms? Oh, I already did that. Okay, in the evaluation of an acute abdomen, why is it critical to ask patients, female patients of childbearing age, their last menstrual period? Pregnancy, right? And is all right lower quadrant pain appendicitis? No. What other things happen in the right lower quadrant? Ovarian torsions. What else? Ectopic pregnancies, which is a surgical emergency. Okay, good. All right. What is referred pain? Why is it important? Why do we care? You guys gotta speak up a little bit. I am deaf.
So like along like certain innervations, like
Sure.
the vision is like very like poorly like like so it's not that same nerve like that dermatomic nerve like it's referred to the body.
Absolutely.
Like that.
Yeah. Also kind of brings back to like your peds, right? Where you have the embryologic type of development, which is why when you have CO2 irritation, you have right shoulder pain. It's a weird thing, okay? But if you have those referred pain locations, if it is in that pain, if it's in that region, right? And you do a shoulder exam, there's nothing wrong. You know, hey, I should probably start looking at the liver, gallbladder, the right upper quadrant, versus, oh, I have shoulder pain. It's probably not anything to do with the left lower quadrant, right? So that's why it's important. So what is an example relevant to an acute abdomen? Cholecystitis, sure. Appendicitis.
Pancreatitis.
Pancreatitis. There's a bunch, right? There's just some, diaphragmatic irritation. So if there's blood, if there's stool, okay, you're gonna have diaphragm pain. You have that early appendicitis with that periumbilical pain. It helps with the history taking, making sure that you're asking the right questions. All right, what exam is elicited by deep palpation of the left lower quadrant causing pain in the right lower quadrant? Rovings. Okay. What is rebound? What hurts? What is a positive rebound? Hurts when you pull up, like when you let go. Okay, doesn't really hurt, maybe a little sore when you press down, but it hurts when you let go. What is a fluid wave indicative of?
Ascites.
Ascites. What about psoas? How do you do a psoas?
Straight up and lay down.
Straight up and you press down. Kind of like a backwards straight leg raise, right? Remember when I was saying in class that you can do the psoas and obturator at the same time, you put their leg up, press down, it's still activating that psoas a little bit, you can still have, and then you can turn at the same time. And if they have pain with both of those, you most likely have appendicitis. Good. All right. Now, what is the gold standard of imaging for diagnosing appendicitis in non-pregnant adults? CT is not enough. What? CT what? No, CT what? CT abdomen pelvis. Is that the whole, yeah, with contrast, okay? I'm not just gonna ask you CT, I'm gonna want you to know the entire thing, okay? There's certain things that with contrast, without contrast, with barium, without barium, just knowing that it's a CT doesn't do you any good, okay? So it is CT abdomen pelvis with IV contrast, okay? What can you do before that? That is the gold standard, but where else can we find it? Ultrasound, good. All right, differentiating the management of non-perforated appendicitis versus perforated appendicitis with a contained abscess. What are you gonna do? How long are you waiting? 6 to 8 weeks. Okay, so everybody heard that? So if it's got an already abscess formation, you're draining, you're giving IV antibiotics, you're waiting 6 to 8 weeks before you go in and then do the appendectomy. Versus if it's non-perforated, what do? With a appendectomy, laparoscopic or open appendectomy. Good. Okay. When would we consider doing an XLAP? Not perforated. What is the indication? So you have a perforated appendix with an abscess. When do we have to go to do, when do we not wait? Frank contamination, which leads to sepsis, which leads to like peritonitis, sepsis, right? If they come in shocky and septic, we don't wait those 6 to 8 weeks, okay? If we do the CT and we find a nice ball of abscess that's walled off, that nice, remember hopefully you learned this in radiology, that thick walled or that hyper echoic type of wall enhanced abscess on CTs. If it's got a nice wall enhancement, that means it's been there a minute, we can drain that with a drain. Versus if it's just everywhere and the patient's septic, there's nothing to real drain, right? We have to go in and wash them out. They're gonna have complications, we just kind of take that as it is, okay? All right, what are the two main groups who clearly benefit from laparoscopic appendectomies over open? Women and obese. Why women? Not just pregnant women, but women in general. I heard anatomy, but what anatomy? Not GU. It's kind of GU, but it's not. It's genital stuff, right? It's actually looking at the fallopian tube. We can look at the ovaries. We can look at the uterus. Versus if we do open, we only have this little tiny thing. We pull out the appendix and we put it back down. Okay, we don't actually see any of the other female anatomy in there. So if we are at all like, yeah, it looks like the appendix, but talk to a surgeon. Sometimes we go in there and the appendix looks absolutely normal and there's something else going on, okay? So doing a laparoscopic versus an open on a female will actually help us do less procedures because we can see other things in that realm, okay? And then for obese people, male or female, okay? Open is just one incision. Okay, if they're morbidly obese and we start sticking 3 ports in, that's 3 other different sites that then they have to try to close when they have a large skin burden. Okay, most likely not going to heal correctly. So if we can just do it over a little tiny incision versus a big one, or 3 little ones, then we'll do that. All right, what is Boerhaave syndrome? Okay, I'm hearing tear of the esophagus, acutely, full thickness, half thickness, what? Full, right? So it is a surgical emergency, okay? What's the main symptom you're gonna have? Vomiting blood, right? Okay, what is Meckel's triad? Remember that one? Nope. Not Meckel's diverticulum, Meckler triad. This is to help diagnose Boerhaave. What do you think it is? Vomiting? Not necessarily blood, but vomiting? No. Subacute emphysema, absolutely. And then what? If you have a full thickness tear of your esophagus, what do you think the patient's gonna come in with? Maybe, but that's not part of the triad. Maybe I heard it. Chest pain, right? Tearing your esophagus hurts like hell. So yeah, vomiting, chest pain, and subacute emphysema. That is Meckler's triad, okay? Yes, you're gonna have bleeding. Yes, you'll probably be hypotensive. Yes, there's gonna be other things, but in terms of Meckler's triad, for Boerhaave, that's it, okay? What is the difference between Boerhaave's and its sister? What do you think? It's Mallory Weiss. So what's the difference? Partial tears, right? Can a Mallory Weiss turn into Boerhaave's, potentially? Yeah, if the retching continues, yeah. All right, moving into hernias. What's the difference between type 1s versus type 2s through 4? Okay, let's say this. What is a 1? What it says, right? It's sliding. It goes in and out, okay? That's the esophageal hernias, okay? Just the esophagus, just the JE junction, or not the JE junction, the LES, okay? It goes up and down, okay? GERD's a really big symptom of that. What is 4? It's like part of the stomach, the LES is up, right? You know, maybe other intestines with 4, okay? Part of the intestine will be up there, versus 3 is just part of the stomach and the LES. 2 is just, oh, I should copy that chart. Either way, it gets worse, okay? Normally with 2 through 4, that doesn't slide. It's just up there. What do we do to fix it? Nissen complications, yeah. You have to pull everything back down. All right, close up that diaphragmatic hole, make it tighter. Good. All right. What is the primary surgical treatment for GERD? How do we surgically treat GERD? What's our gold standard?
Stomach graft.
Stomach graft, which is? You just said it.
He said it, I didn't hear.
Nissen fundoplication, right? Nissen. So same for hernias, because GERD is one of the number 1 causes of hernias are one of the number 1 causes of GERD, right? So most of the time, the surgical treatment for GERD is to try to close down that LES and make it more competent. Okay. So stretching that part of the stomach, either 360, 180, depending on how bad their symptoms are. What's another one that we can do? The magnetic, right? The links. The links. Yep, good. All right, you have a patient with chronic GERD, presents with new onset dysphagia, first to solids, now to liquids. EGD reveals salmon colored mucosa at the distal esophagus. What is the most likely diagnosis? I heard it. Barrett's. Good. And Barrett's is? It is cancerous. Most likely, it is pre-malignant, but if you see Barrett's, you gotta do something about it. Right. Barrett's normally means cancer. Alright. What is the most common cause of small bowel obstruction in patients with a history of abdominal surgery? Post-surgical adhesions. Good. Okay, what will you see on x-ray? Dilated loose bowel. Right. What do the small intestines look like? Stack of coins on its side, or that ladder, right? How do you differentiate between that and a large bowel? Haustra, yep. What does a haustra look like if they're dilated? Yeah, big pouches, good. Good. Okay. What's Charcot's triad? right upper quadrant pain,
plus,
jaundice,
and then with that, you add,
hypotension, and what was the other one? Altered mental status. Yep. Alright. So if you have Charcot's triad, that indicates what? Say that louder. No?
Ascending cholangitis.
Cholangitis. Acute cholangitis. Okay, Charcot's triad is cholangitis. And then what if you add the Reynolds? Yeah, it's basically cholangitis that's now subject. Okay, alright. What is a positive Murphy sign? So, the pause of inspiration on palpation of the right upper quadrant. Okay, what does it suggest? Something wrong with the gallbladder. Okay. What if you have painless gallbladder? Like what if it's but you feel the gallbladder, it's palpable, cancer. What type of cancer? Pancreatic cancer, good. All right, what's the initial imaging study of choice for suspected acute cholecystitis? What do we do first? Ultrasound, okay? You'll hear a lot in phase 2, it's called ruckus. Right upper quadrant ultrasound, right, ruckus. Then what's the most accurate? Yep, IDA. We don't use it very much, but it's still the most accurate. Good, so right upper quadrant ultrasound is our initial study. And then the HIDA is the most accurate. Okay, what is the definitive treatment for symptomatic polylithiasis? Cholecystectomy. Okay. Get used to talking in medical terms. It's not just removal of the gallbladder, right? It's not just take it out. Actually try to name the surgery. Okay. What's the difference between open versus laparoscopic? Small camera holes versus big, large, open from xiphoid to, anterior axillary line, right? What do we need to do before imaging? Or what imaging do we need to do before surgery? Potentially.
Right X-ray.
If you're going in for a cholelithiasis, maybe ERCP, it's just like, what do you gotta think about? Yes, doing a chest x-ray, because you're still going into surgery, you still wanna know what the lungs look like. But ERCP maybe, MRCP if they're pregnant. Okay. What's the imaging called intraoperatively? Which is? Intraoperative cholangiogram. Very good. What does it show us? Not the gallbladder. Common bile ducts, right? Good. Alright, is it diagnostic? Diagnostic and therapeutic? Only therapeutic? Both, right? Diagnostic and therapeutic. Okay, you sneak that catheter in there, shoot dye in it, it'll see a stone, we can do something about it. Alright, you have a patient who has jaundice, found to have a palpable non-tender gallbladder on exam. What is this sign called, and what is it highly suspicious for? One of the ones I couldn't say. Yeah, Koestever's sign, and it's highly malignant, or highly suspicious for malignant obstruction of the common bile ducts from pancreatic cancer. Good. Alright. Which serum lab test is more specific for acute pancreatitis? Lipase. Lipase is more specific for acute pancreatitis. Okay? Amylase can be elevated by other things, but normally if your lipase is greater than 3 times the normal high, then it's really indicative of pancreatitis. Okay, what is a pancreatic pseudocyst? Who do we see him in? Alcoholics, but they normally have what type of condition? Hmm?
Liver issues.
Suffer the liver.
Nope. Give up. Chronic pancreatitis. Right, we normally don't see this in acute. We need to have that chronic phase, that chronic inflammation of the parenchyma of the pancreas. Okay. All right. How do we do it? What do we do to treat it surgically? And when? Hmm? I heard Whipple. We'll get back to that. So it's a non-symptomatic, so asymptomatic cyst.
Monitor.
You could monitor depending on size. If it gets too big, probably first do a drainage, so percutaneous drainage, okay? And then, most likely, depending on how chronic it is and if it recurs, okay? Then we may go in and actually take parenchyma as well to try to get that cyst wall out, okay? But most of the time, how we treat it is that percutaneous drainage, initially at least, and then if it continues to happen, then we'll do more. All right, what is the double duct sign? Okay, pancreatic duct and common bile duct. Good. What's the significance? Pancreatic cancer, right? Good. Will you see this normally on, like, say, a pancreatic tail cancer? No, so it's really got to be at that junction, right? Pancreatic head. All right. What's the most serious potential complication after splenectomy? Nope. Overwhelming infection. Okay, the OPSI.
Lots of shots before they leave the hospital.
Yes, yes. So remember, the spleen is responsible for keeping track of that vaccines that we get for encapsulated bacteria. Okay? So if we take that spleen out or we kill it completely, they no longer have that ability to protect themselves against those encapsulated bacteria, which are what? Meningococcal, hemp, okay, H flu. Is it just strep or strep pneumonia? Okay, and remember there's like 2 different types of meningococcal vaccines right now, so I think we normally give them 4. Say we're doing a planned splenectomy, when do we do these vaccines? 2 weeks before we take it out, and if it's a traumatic splenectomy, 2 weeks after, or say they get out at 3 days. Are we gonna call them back to do the vaccines at 2 weeks? No, we're gonna do either day of discharge or 2 weeks, okay? And make sure that we send them home with a good boost plan, okay, that they can show up to their primary care and say, hey, I need to have these vaccines at this time. Alright, good. Alright, what's the difference between diverticulosis and diverticulitis?
And them being inflamed.
Yeah, so diverticulosis is the condition, okay? Can cause bleeding, but most of the time it just is dormant. It's an outsacking, like the wall of the intestine of the colon is outpouching, right? Diverticulitis is when those outpouchings are inflamed. What type of symptoms do you think you'll have with diverticulitis? Blood? Bright red blood, melena, metachesia, what?
Bright red blood.
If it's left-sided, bright red blood. If it's right-sided, potentially melena or hematochezia, right? It depends. Depends. What else? What else are we gonna see with diverticulitis? Pain. Pain where? Left lower quadrant if it's the left side, or if it's the sigma or the cecum, right sided. Do you think they're gonna have fever? Think they're gonna be sick? Maybe have a little white count? Leukocytosis? Okay. Alright. Did we talk, I don't know, I know it's on the slides, but did we talk about the Hinckley classification for perforated diverticulitis? Okay. You guys get a little special treat. So these are the 1 through 4. So 1 is just, you have a little abscess, nothing, we give bowel rest, IV antibiotics, all the way to Hinckley 4, which is what we were talking about, the generalized fecal peritonitis. Okay. So depending on, this, just like with most classifications, and whenever the larger the number, the worse it is, okay? So do you think we're gonna do an X-lap on a Hinckley 1? No. If it's just a little abscess, walled off, we're not gonna do an X-lap. But if it's frank fecal peritonitis, we don't really have a choice. We have to go in and do an X-lap and wash them out. We have to get source control. All right, how are internal hemorrhoids graded? Right, 1 through 4, that's on the slide. So what's a 1? Do they? 1, so it goes, like, slips down, goes back in spontaneously. Okay, what's a 2?
Manual reduction?
Okay. I think we're a little ahead of ourselves. So 1, it bleeds but does not prolapse. 2 is when you spontaneously get back, okay, when it spontaneously reduces. 3 is when it requires that manual reduction, okay, and that 4 is we can't reduce it at all. Super important as primary care providers, knowing what type of it is so that you can tell the surgeon, hey, I have a class 4 or a grade 4 hemorrhoid, internal hemorrhoid, I think it needs to be seen. Okay. How do we differentiate between internal and external hemorrhoids? The dentate line, good. Pain, bleeding, yeah, they both, yeah. Which one's gonna most likely have that thrombosed hemorrhoid? External, good. All right, what's the classic presentation of an anal fissure? Fissure, anal fissure. Posterior tear. Okay, what if you have multiple tears? What do you gotta think? Crohn's, some other type of, there's other types of, intestinal tract issues. So yeah, if you start seeing multiple fissures, multiple tears, then we have to look for other things. It's not just a tear, okay? All right. What is toxic megacolon? I don't think I said that in this class, but I know you know it. You had GI already. Pull it out of the recesses, right? What is it? So the colon, right, kind of mega, right, gets huge, full of stool, full of infection, okay? Normally we see it with Hirschsprung's, but we can see it in other things, other like colon cancers, colon obstructions, whatever. We can actually can produce that megacolon, and because it can't, our bodies can't, relieve it or evacuate it, it becomes infected and toxic, okay? This is where you can actually get that bacteria translocated into your actual peritoneum and have a septic belly. So what do we do to treat it? remove the obstruction, but I mean,
Antibiotics. Cut out the valve.
how do you think we're gonna treat this? This is so big that they're becoming toxic and septic. Surgery, what type of surgery? Probably a colectomy. Yeah, we're gonna do an XLAP and we're gonna take out the whole disease part of that colon. Okay, this is not something that, like obstipation, where we try to get it to pass and give it antibiotics, like, no, this is at risk of tearing and actually having perforation into the gut, into the peritoneum, so we will do surgery, okay? All right, patient in the ICU develops hypovolemia. What is the most, yeah, reliable, sorry, I had a brain fart. Okay, what's the normal urine output? 0.5 to 1 milliliter per kg per hour. Okay, 0.5 to 1 mil per kg per hour. Say it is a hypovolemia after post-op. Are we gonna give them blood, fluid? Most likely fluid, unless it's ortho. Ortho, we may have to check their hemoglobin to get blood. But yeah. Okay. Alright. Patient arrives, found to have Kerr's sign. What is that sign and what does it suggest? Yeah. You have left shoulder pain, that's that referred pain. Okay, what does it mean? Anything, right? Like you have diaphragmatic irritation from blood, pus, poop, whatever. Okay? So yeah. Some sort of peritoneal cavity irritation to the diaphragm just goes the other way. Most likely with the ruptured spleen. But it could be from anything. Okay. Alright, what is the advantages of lactated ringers over normal saline? It doesn't prevent acidosis, right? It has that nice balanced, kind of almost, it's as close to an isotonic type of fluid we can give, okay? So thinking acidosis wise, if we give just a large bout of NS, what are we at risk for? Hypokalemia, right, good. Okay. Patient with small bowel obstruction, the surgeon orders an NG tube. Low intermittent wall suction. What is the purpose of this NG tube? Decompressing the stomach, yeah, decompressing the proximal bowel, absolutely. What do we use that for? What conditions do you think of when we have to decompress the stomach? Sure, gastric outlet syndrome or obstruction, sure. What other things? Ileus, absolutely. That's the number one thing that we put an NG in for. Absolutely. Okay. All right. Your patient has peptic ulcer disease. What are the 3 main indicators for surgery? Say it louder. I can't hear you. All I hear up here is mumbling. Bleeding? Hypovolemia? Or same thing? Bleeding causes hypovolemia? Huh? Perforation, absolutely. You said it earlier. Just like a second ago, 30. Yeah, so obstruction. Right? If your peptic ulcer disease is so severe that it's so swollen that nothing, like especially if it's a duodenal ulcer, right? Because peptic is duodenal or gastric, okay? If it's obstructed and nothing is going down, we put an NG tube on and we'll most likely go to surgery to fix it. Okay. Or from scarring. What is the most common cause of lower GI bleeding in adults? Itis, or Lotus. This slide says Lotus. Either or. Okay. The main way that you can differentiate between diverticulosis bleeding versus diverticulitis bleeding is pain. Okay, you're gonna have that belly pain. Okay, diverticulosis has no infection or no inflammation. Okay. All right. When you have refractory hypokalemia, what do you gotta fix first? Magnesium. Very good. Okay. When you have that generalized fecal peritonitis from diverticulitis, what is our surgical management? What do we start with? How do we get into the belly? Is this gonna be laparoscopic? It's open, but what's that term? Just laparotomy? Exploratory laparotomy. Alright? Yes, kind of the same thing, but exploratory. XLAP, right? Those are the XLAPs. Then what do we do to fix it? We go in there, we can't just, irrigate it out. What do we gotta do? It's a perforated diverticula, most likely of the left lower quadrant of the, sigmoid colon. Not gonna graft it. Cut it out, right? What's that word? Excision, yeah, sure. We're not gonna do a full colectomy. Jesus. A partial, but if we're taking that left lower quadrant, let me tell you, most likely because it is, okay, so you have fecal peritonitis, okay? That means the belly is full of poop and grossness. Do you think we're gonna try to anastomose those two ends? No, right? Never gonna, you have to anticipate we're gonna have belly abscesses, so we're not gonna reattach those right now. So we're gonna bring, we're gonna bring up that colectomy, or the colostomy, okay? And have a rectal stump for later reattachment, possibly. But what is that procedure called? Hartmann's, very good. Okay? So if you have somebody with a left-sided perforation, a left colon perforation, and there is poop and, infection everywhere, we're gonna do an XLAP and then a Hartmann's. Okay, we're gonna remove that section, we're gonna bring up a colostomy and leave it along, as long as a distal, rectal stump as we can, so that we can re-anastomose later on. All right, what is total parenteral nutrition? What is the role? Nutrition. Is this per mouth? No, so it's, nope, that's still by mouth. We're still using the gut. If you're talking parenteral, right, you cannot use the gut. So it's not gonna be a G tube, a J tube, a PEG tube, an NG tube, a Dobhoff, right? We're not using the gut. So this is in a vein, parenteral. Okay? This is, and when we do total parenteral nutrition, we want like a central line, okay? TPN, okay? Yeah, so when, especially like for those patients that we just did surgery on the gut, or we leave them in discontinuity for a few days because they got shot up or stabbed or whatever, we'll start them on TPN, so they're still getting nutrition through their blood, but not through their gut. Okay? What is the difference? What is TEN? What is that? Enteric, yes, enteral nutrition. That goes through those PEG tubes that, Dobhoff. That's when we can use the gut. Okay? May not start at the mouth with the J tubes, G tubes, all that stuff, but it's still using the gut. Okay? All right. Patient vomits bright red blood. EGD reveals a linear mucosal tear at the GE junction. What is the diagnosis? What is it? Mallory Weiss tears. How do you treat it? wanna do an EGD. Right, try to clip or use cautery or that, localized epi, okay? Alright, what's the difference, pathophysiology of Crohn's versus ulcerative? Which one's which? Okay. Intramural. What's the main big difference?
Crohn's is mouth to anus.
Crohn's is mouth to anus. Ulcerative colitis is just the colon. Okay, so if you have mouth sores and other things, it's not necessarily gonna be used, ulcerative colitis. Okay, when you're looking at tissue types, what's the type of tissue that you're looking for? I absolutely asked this on the slide and I made sure I stopped. Granulomas. Remember granulomas? Which one has granulomas? Crohn's. Right? Those, no. Yeah, Crohn's are the non-caseating granulomas versus ulcerative does not. The pants loves asking that question. Okay. Alright, patient is found to have a carcinoid tumor of the appendix after an appendectomy. Or surgical pathology found it, okay? What feature of the tumor is most likely or most important to determine if other surgery is needed? Size. So what is that size? 2 centimeters, right? If it's less than 2 centimeters and you're good, greater than 2 centimeters, mainly greater than 5 centimeters, you're not so great. Okay. Okay. What's the other tissue pathology type of appendix cancer? Say it louder. Adenocarcinoma. Okay? So if you have a carcinoid tumor that's less than 2 centimeters and it's not right at the incision mark, what do you have to do? Nothing, right? Or no, if it's at the incision mark. Right, you probably have to do something if it's at the incision mark, okay? Either you most likely will have to do what type of surgery? Huh? Not an X-lap. Not emergent. Huh? Hemicolectomy, which side? Right-sided, hemicolectomy, very good, okay? So if it's at the tail of the appendix, we got all of it. If it's not on the surgical margin, most likely we're good. We already cured it, okay? If it's on that margin and we can't guarantee that we didn't take all of it off the cecum, most likely they're gonna get a right hemicolectomy, okay? If they have adenocarcinoma, what's the treatment? Adenocarcinoma is bad, right? Anytime adenocarcinoma is in the body, it's bad. So what are we gonna do? Right hemicolectomy, okay? Cool. All right. Do we need a break, or do you want to just keep going? I mean, I have 12 more slides, but the last 8 slides have lots of questions on them. Push. All right. What's the role of an ERCP? What does an ERCP do? So it's endoscopic, retrograde, cholangiopancreatograph. Hard to say. These are okay. Is it diagnostic? Is it therapeutic? Yes. Okay, so what do we use it for? Speak louder and not muffled. I'm just, that's all I hear. Not a gallstone. Well, I mean, but what are we trying to get at? Common bile duct. We're trying to take that stone out of the common bile duct for choledochal, right? Or, okay, if we can't remove the stone, what else can we do? Cut what? Cut what? No. We're gonna do a sphincterotomy. Remember that sphincter of Oddi, we're gonna cut it to let that stone come down on its own. Okay? Oh, my computer may die. We'll see. Okay. Let's see if I got all the points off of that one. Sphincter of Oddi. Yeah. Okay, you have a patient with cirrhosis, abdominal pain, CT scan, abdomen and pelvis shows a new enhancing mass of the liver. What is most likely diagnosis? Cancer until proven otherwise, right? Okay. Yep. Hepatocellular carcinoma until proven otherwise. What if the patient is female on OCPs? What liver pathology do you think you'll have? Hepatic adenoma is good. Okay, how do you treat it? It just stop the OCP, right? If it doesn't resolve or if it's becoming symptomatic, then you can go in and resect it. But most of the time, just taking them off of that oral contraceptive or any contraceptive, hormonal pill or whatever, like, it'll treat it. All right. Pre-op pearls. Okay, what are the two main goals of pre-op evaluations? Yeah, so maximize health and prevent complications. Good. What, when ordering labs and imaging, do we order everything? How do we decide what do we order? Comorbidities, what we suspect, right? Okay. What home medication do we hold the day of surgery? ACE inhibitors, not ARBs, just ACEs. When do we start prophylactic antibiotics? An hour before OR or an hour before
Incisions.
cutting? An hour before the incision. Okay? A lot of times if we are waiting to go to the OR, we may have to dose them twice. What does that do? Why do we do that? It prevents something. What type of infection? Sure. We are preventing bacterial infections where? Okay. You're on the right track. The site of the surgery, gallbladder? We're trying to prevent gallbladder infection? Huh? But the surgery site may be the colon. The surgery site may be the brain.
The incision site?
Say it out loud. The skin. Okay, the incision. Okay, not the surgical site, the skin. Okay, because a lot of times they don't get confused. Okay. All right. What risk stratification do we use for non-cardiac surgery to help prevent major cardiac complications? The MACE. Very good. And then I have say stuff up there, but I think we went over that pretty good. What are the two antibiotics that we choose, and why? Cefazolin for
Skin.
just skin. If we think we're going to touch bowel, metronidazole and flagyl, metronidazole and ciprofloxacin. Good. Are these PO or IV? IV all day long. We do not give PO. Okay, that for pre-op. Post-op, different story. All right. Oh, that should be in the end. I'll fix that. Fluid and electrolyte pearls. What is the normal urine output again? 0.5 to 1 ml per kg per hour. Yep, good. Okay. What is the correct way to manage fluid resuscitation in a septic or critically ill patient? Think back.
Initial bolus.
Huh?
Initial bolus followed by.
Okay, initial bolus followed by what? Are we just gonna give them like 10 liters of fluid?
No.
Right, so what is that called? Hydration, sure. Part of it. You'll hear this a lot. Judicial fluid resuscitation, okay? Old schools, we just gave them fluid after fluid after fluid, right? But then that caused a lot of problems with heart failure and, lung edema and all bad things. So judicial lung resuscitation, which uses what I just talked about, urine output, to dictate how much fluid we have to give, okay? If our rate is too high and our urine output goes through the roof, we decrease the rate no matter what we think. Okay, we use that urine output, which most likely will involve a Foley, to figure out if they're actually getting enough fluid or not. Okay? What symptoms do you start seeing when you have a patient decompensating into a class 4 shock? What do you see? Altered mental status, more so like, lethargic, they're gonna be almost in a coma, they're not gonna be conscious. What else? Tachycardia to what? 140 and above? What else? Hypotension to what? Like, a little bit, or probably less than 80, like significant hypotension, okay? It's hard to put a number on it because a little old lady could be normal at 90, so it's whatever significant to her in order to get to that altered mental status and that coma, okay? But we have tachycardia over 140, what else? We just talked about it.
Urine?
The last slide, just talked about it last. Urine output, right? What is the urine output doing? They're not, right? The blood supply is trying to go to other essential organs. The kidneys are not being, not gonna be infused, so you have basically no urine output because the body is trying to conserve as much of that intravascular fluid as possible, okay? But what does that cause after? What do we have to watch out for after we resuscitate them? So if the kidneys during the actual attack, during the episode, is not getting, blood flow, what are we gonna see after we get blood flow return? Yes, but it's a simpler term than that. We anticipate we're gonna have acute kidney injury, right? Their creatinine BUN is gonna be up, okay? It is technically kind of a reperfusion, but it's more just acute kidney injury, okay? All right, what are the 3 different fluid management strategies? Maintenance, resuscitation, and replacement, okay? What is maintenance? What do we use maintenance for? Baseline, yeah, so NPOs, they're just maybe a little bit dehydrated, okay? What is replacement? Maintenance plus, so they're staying on that maintenance dose because they're most likely still NPO, but what are we accounting for? Extra losses, okay? So we're checking that NG tube output, maybe they have diarrhea, it's whatever they're, like say they have an additional 600 milliliter output from their NG tube, right? We still have to give that back to them. The maintenance is not gonna really do anything for that, okay? So most of the time we'll switch them. So when we're on maintenance, what type of fluid is it? Most of the time? D5 half or D5 normal, with a little bit of potassium, good. Then when we're in replacement, do we use D5 at all? No, normally we use LR, okay? There are gonna be some surgeons or some medical providers that will keep them on their maintenance and do a bolus of an LR, that's fine. But in terms of replacement, it's replacing whatever they're additionally losing, and it's most likely gonna be LR, okay? Some other times they're gonna just change the entire fluid set over to LR and just do a straight rate with that addition into it, okay? So it's different. What is resuscitation? When are we using resuscitation? Bleeding, but just any bleeding, a little bit of bleeding, I have a paper cut bleeding. Shock, right? They're sick, they're critically ill, they could be septic, right? So, really is no rate like we bolus. It is still that judicial, but we're measuring it to urine output. Good. Okay. And then I think we already talked about this, the hypertonic saline, what do we use it for? Head injuries, severe hyponatremia, with seizing. Okay. Alright. Moving on to the acute abdomen pearls. You have air under the diaphragm. Which side is abnormal? Right side. Good. If it's the left side, what do you have to determine? If it's the gastric bubble, right? Okay. When looking at the different sections of the bowel, how can you differentiate them on X-ray? We talked about this already. Location, what it looks like, right? That ladder versus if it's a horseshoe, if it's the stacked coins. There's a bunch of different ways to differentiate, right? If there's any concern for bowel perforation, which medium, contrast medium do you use? Gastrographin, sure, what type of? Iodine-based, water soluble contrast. Okay, so that's iohexol, gastrographin, omnipaque. Explain what an ileus is. Paralysis of that peristalsis. Okay, that antony of the stomach, intestines, colon. Okay, how do you treat it? Support fluids. NG tube, most likely. Now, NG tube plus or minus, it depends on their symptoms. I've taken care of patients who did not want an NG tube because they were not actively nauseous. Okay, if they are actively vomiting, they get an NG tube. But if they can keep stuff down and they're not going to drink or eat anything and they're not actively vomiting, sometimes we can hold off because they are very not tolerated very well. Okay, perfect. All right, appendicitis. What's the most common cause? Fecalith, but what's more appropriate? Okay, if it's appendix, if it's in the appendix, so fecalith can happen anywhere, right? It's obstruction, but it's caused by, fine, I'll give you fecalith, but appendicalith? Okay. I'll take fecalith too, but the appendicalith is really, the whole thing. What are the important signs and symptoms? Fever, pain where? Not as, well, hopefully it's not diffuse. Yeah, starts periumbilical and then moves to that right lower quadrant, alright? Yeah, hopefully if it's gotten to diffuse, it's not appendicitis anymore, because then you have, right, needs to go to the OR. Alright, right lower quadrant pain should also think of what other diagnoses? Right lower quadrant pain. Kind of talked about it already, so ectopic pregnancies, UTIs can cause right lower quadrant. Do I have right upper quadrant? Wait a minute. That should say right lower. I'll fix that. So, sorry. You were right on the right upper. Right, I want right lower because we're on the appendix slide. Okay, right lower pain. So you have ectopic pregnancies, UTIs, you can have viral gastroenteritis, kidney stones, ovarian cysts, PID, Marcus diverticulum, all that stuff, okay? How do you treat appendicitis? What is the surgery? Laparoscopic appendectomy or open appendectomy, okay? What if it's perforated and walled off? Antibiotics, perk drain, good. I'm being deliberate on certain things. I see smiles, so kind of the smirky ones. Okay, esophageal, stomach, and small bowel. What is the gold standard for GERD testing? An EGD helps, but it's not the gold standard. pH monitoring, right? You got to use that EGD to put that little monitor right next to or right above the junction, the LES. Okay. How do you diagnose Zenker's diverticulum? Barium swallow, right? What do you avoid? EGDs. Good. Everybody understand why? Okay. What is the most common symptom associated with alkalasia? Dysphagia, right? That pain with swallowing, okay? What is the most common complication? If you can't swallow and you're constantly regurgitating food, aspiration pneumonia. Okay? Alright, why should disc and button batteries be removed promptly? Liquefaction necrosis, and that leads to perforation. Do you get an eschar with liquefaction necrosis? No. So those are acids, right? If it's an acid, you're gonna most likely get an eschar. And then that leads to like not necessarily perforating because you have that nice thick scab. Okay? But with alkalosis or alkalotic type things like batteries, okay? That's why they're called alkaline batteries. They're gonna liquefy the tissue and not ever have a chance to like really cause that eschar. It's just gonna perforate all the way through. Okay. What additional imaging do you need to consider for esophageal cancers? Chest, SCT, chest and pelvis, sure. What else? Barium swallow, maybe. You're most likely gonna use those to help diagnose, but like additional. You're a primary care provider, you have someone who, comes in and they have just been diagnosed with esophageal cancer, and they have never done this type of study before. Nope. They're already seeing their surgeon. You as a primary care provider, what do you have to kind of think about what does esophageal cancer like to go to? Bone, right? So if it goes to bone scans, right? Bone scans. That's one thing that we forget a lot of times is to not do a bone scan. All right, what's a great way to differentiate between gastric and duodenal ulcers? Pain. Okay, so what is the pain profile for gastric ulcers? Short after eating, right? It's very immediate. 15 to 30 minutes, but immediate. What about duodenal? 2 hours. So food, the pain gets better with food. Good. All right, hepatic curls. We already talked about this. Again, common thing that's missed. Common liver lesion found in women with OCPs. Hepatic adenoma, are they dangerous? Most likely benign. When do we remove it?
Depression. Compressing out.
Yeah, when you actually have pain, right? Or if you stop the OCPs and it doesn't get better. What liver cyst is pre-malignant? I'll give you a hint. It's a cystadenoma. Hepatic cystadenoma, right? Pre-malignant. Okay. Do we remove it? Yes. Why? Yeah, because it's pre-malignant. Okay. How do we remove it? Resection. Okay, open resection. Okay. We're not going to do a needle. This is one that's still like fluid filled, it's still a cyst, right? But because it's got all that septation in it, it looks gross. We're not going to try to piecemeal it out. We're going to just resect that whole thing and try to get the whole thing out. Okay. All right. What complications do we need to watch for patients with ALF and FHF? What are they even? What is ALF? Acute liver failure with FHF. Fulminant hepatic failure, fulminant liver failure. What do we need to watch out for? If the liver is dying, what do we watch for?
Encephalopathy.
Encephalopathies, Coagulopathy is good, right? If the liver's not working, your clotting factors are not gonna work, and they're most likely gonna bleed. Okay. All right, what are the 2 scoring systems that we use to help guide management in patients with ALF? How do we classify them? What are the 2 scoring systems that we use to help really classify? MELDS, and I think I heard it? Class Qs, good. Okay. All right, what are some causes of pneumobilia? What is pneumobilia? Air in what ducts? Bile ducts, right? In the biliary tree. Good. What is it? Or what causes it? Huh? Maybe? Yeah? Gas producing infection, yeah? So, like necrotic gallbladders, do you think you'll get it with gallstone ileuses? Right? Gallstone ileuses, absolutely. Right? Why? Remember what a gallstone ileus is. So it's obstruction of the small intestine, right, from a gallstone. But how did that gallstone get there? It fuses, right? It fuses with the wall, and it actually, like the gallbladder wall is attached to the small intestine. Okay, so once that gallbladder comes out, now you have an opening between the gallbladder and the tree, meaning all your farts are up into your liver. Great, right? Okay, you're gonna always remember that now. And then what do we do that can cause pneumobilia? If we're actively looking, not type of surgery, ERCPs, right? If we're sticking a camera up through those ducts, we still have to blow air up into them, and that can cause air backtracking up into the liver. Good. All right, what's the treatment for a liver cyst? That's asymptomatic. Observe. Okay, otherwise, just a normal liver cyst. We just do a needle aspiration. We just remove that fluid. Okay. What about polycystic liver? What's the treatment? What do you think? Transplant. Yeah. Most of the time we observe until it gets so bad that you need transplant. Okay. Hepatic hemangiomas. Let's say asymptomatic hepatic hemangiomas. Asymptomatic what? Observe. What if they become symptomatic? They resect. Okay? Think of hemangioma as like a ball of vessels, right? We're not going to try to aspirate that. We're going to try to resect the whole thing. Versus if it's a cyst, the only cyst we resect completely is that cystadenoma. Okay? But you'll know. Okay? Like simple liver cyst will not have all that schmut in the middle. Okay? It's going to be nice walled off. It's going to be nice circular. There's going to be homogeneous type of fluid in there on imaging. When you have that cystadenoma, it's going to be septated. It's going to be all heterogeneous. It's going to look funky. It's going to look gross. Those you resect. The simple liver cysts you can aspirate if you need to. Okay. What about hepatic adenomas? We talked about this. Now this is, I think, the 3rd time we talked about this. If it's asymptomatic, less than 2 centimeters, or less than 2 centimeters. If it's less than 2 centimeters for hepatic adenomas, observe. All right. If it's greater than 5, or symptomatic, are we going to resect or needle aspirate? Resect. Everything, the whole thing. Good. Focal nodular hyperplasia. Bad or not so bad? All right. What do we do? What do we do to treat that? Observe. Okay. And then HCC. What is HCC? Hepatocellular carcinoma. Carcinoma means bad. So what are we going to do? resect. What if resection doesn't work? Transplant, right? There is also another thing called ablation. There are some types of cellular carcinomas that we can actually use IR for and do a CT guided, we insert like a needle and then we ablate it with certain things. All right, gallbladder pearls. What is the first line treatment or first line imaging for right upper quadrant ultrasounds? Oh shit, I already did that. It's late, guys. All right, so first line imaging for right upper quadrant. Ruckus, it's an ultrasound. What is the difference between ERCP and MRCP? Which one's therapeutic? ERCP. All right, describe cholelithiasis. What are the symptoms? Colicky pain, okay? You gonna have a positive Murphy's? Probably not, because it's just stones, right? It's not cholecystitis yet, okay? It's just cholelithiasis. So there's no itis, right? There's no inflammation. It's just stones. So it's gonna be colicky. You're gonna have those 5 F's. Do you remember what those 5 F's are? Female, fertile, 40s, fat. Oh shit, I forgot what the one is. Flatulent, there you go. Thank you. Okay? Alright. What's the surgery? How do you treat it? I think I heard it. Cholecystectomy, good. What about cholecystitis? What are the symptoms? How does it differ? You have fever? Yep, so constant versus that colicky. You have a positive Murphy sign now. You have fever. So with fever, you could expect elevated white count. Okay, and the treatment? Cholecystectomy. Okay, what about choledocholithiasis? Bile duct. So the common bile duct is obstructed. Good. Okay, what type of you're gonna have inflammation. Okay, jaundice. This is where we start seeing jaundice. Okay. What is the treatment? ERCP and then cholecystectomy. Okay, you still have to take the gallbladder out because that stone came from somewhere. But the immediate treatment is ERCP. We gotta get that stone out of there. If we can't do that, if we can't get it from retroactively, like with the ERCP, then we'll actually take them to surgery, take the gallbladder out and do an IOC and see if we can't flush it. Or, you know, there's a bunch of different ways to get around it, but normally, if everything goes according to plan, it's that ERCP, then cholecystectomy. Okay, and then what's cholangitis? Infection, okay, of the gallbladder itself. Okay, so you have choledocholithiasis plus the infection. That's why you have it as an itis. Okay. This is where you start having the Charcot's triad. So fever, jaundice, white count. Okay, and then that Raynaud's. Okay. How do you treat it? ERCP with sphincterotomy. Okay. Just like with choledoco, okay, because it's still choledoco, but now it's infected because it's been there long enough. Okay, so you still have to do that ERCP to try to remove that stone. If you can't remove that stone and the sphincterotomy isn't helping, then you can go into an emergent cholecystectomy. But yeah, first line is that ERCP to try to draw that stone out. All right, pancreas and spleen. I have two more slides. Pancreas and spleen. So what lab is most predictive of acute pancreatitis in the first 24 hours? Lipase. Good. What is the scoring system we use to predict prognosis for pancreatitis? Rancid. Good. What is the imaging tool or diagnostic tool we use to diagnose pancreatic cancer? What is the initial study we use? Imaging. Imaging. What imaging are we doing? How do we find it first? Not necessarily gonna see it on ultrasound. So next would be CT, abdomen, pelvis with contrast, okay? And then definitive diagnosis. But how do we get to that biopsy? What do we gotta do in order to get that biopsy in those brushings? Huh? Is it that late?
Yes.
ERCP with? Yeah. Imaging. Biopsies are not imaging. What else imaging wise do you have to do for pancreatic cancers? Ultrasound, which is called, it's not an abdominal ultrasound. What is it? EUS, which stands for endoscopic ultrasound. So it's part of the ERCP. Okay, it's part of that EGD, right? Okay, the EGD is basically what we start with, and then the RCP part is like different things that go down that scope. And then the last part of it is if we actually need to ultrasound that mass to see how much it's invaded. Okay, just doing a top, like on top of the skin abdominal ultrasound isn't gonna give us that invasion. And then we can get actual brushings and biopsies from that mass with both of those. Okay, last one. What is the most common cause of lower GI bleeding? Diverticulosis. If it's infectious, itis. Okay, what imaging do you do or do you avoid in diverticulitis? Colonoscopies. Why? Risk of perforation. What is the other one that we avoid? Not colonoscopies. Nope. Yes, flex sigmoids. So sigmoidoscopy. Basically, it's a shorter colonoscopy, right? But you got to think about that. What situation will emergent surgical in what situation will emergent surgical treatment, wow, I really spelled that wrong. In what situation will we need to do emergent surgical treatment? Perforation with, like actual frank, gross, like peritonitis perforation, that frank, feculent type of material in there. Okay, they're sick. Okay, what polyp tissue pathology is the highest risk for malignancy? Which polyp? There's 3 types, right, that we look for. Which one's the most aggressive? Bilious. Okay, goes bilious, then tubobilious, then I think adenoma, adenomas. Okay, but just think bilious. Bilious, very bad. All right, how do you differentiate between right-sided and left-sided colon cancer? What is the patient going to tell you? The stool. So which one is which? Left-sided has those pencil-thin stools, okay, because it doesn't have a chance to reform afterwards. It's closer to the rectum. Okay, what else? Say you have a right-sided colon cancer. Is it going to be bright red blood? Most likely it's going to be darker because it's had a chance to oxidize, right? Could be melena. Do you think you're going to have melena on a left-sided colon cancer? No, it's going to be bright red. Okay. Do you think you're going to feel a mass on the right side? Most likely. Okay. Maybe not on the left, maybe on the left. Or at least those 2. Okay. All right, which anatomical structure is used to define hemorrhoids? Dentate line. Good. And then, between ischiorrectal and intersphincteric anal-rectal abscesses, which one requires the OR for treatment? Intrasphincteric, right? It's inside that sphincter, it's higher up. Which is the other one that requires OR? heard it. Super levator, good. The other two, which is the ischiorrectal and perianal, are ones that you most likely will be able to treat in your clinics and or the ED. When they get really bad, we have to take them to the OR. And then don't forget, have you guys learned about Fournier's gangrene yet? Has that word ever been?
It's
Yes.
weird.
Huh?
We've seen it before, but not, it's more for like what is it?
Okay, it's not gonna be on this test, but these abscesses can actually, go into that gangrene, okay? Basically eats, it's like, think of Fournier's as, neck fash, okay? That flesh-eating bacteria, but in the groin, okay? It's bad. It's not gonna be on the test, but that's why we kinda try to get these, the internal ones quicker and to the OR for really, global, irrigation and source control, because then it won't cause that. All right. Do you want me to post these? Do you think it's fair to your other students who didn't stick around? All right. I'll fix the two little things that I messed up, and then I'll post it. Is there any other questions? Anything else you need clarification? Yeah.
Were there any specific lab values that we need to memorize? Like a specific range, like,
So the normals will be given.
okay.
Other than that, it's up to you guys to know what's abnormal. If it's on a slide, it's fair game. But the normals, the normal ranges for those will be given. So you just have to really remember, for lipase, right, it's above 3 to 6 times that normal limit, okay?
Yes, ma'am. So I noticed on one of your PowerPoints, you have notes on each of those. Are we test up the slides or part of the initial notes as well?
Just the slides. Just the slides. No, the notes are mainly for me. I can't test on those. What else? Females. Yes. But no. No. Yes. So, now you got me all screwed up. So, open is better for obese and probably pregnant. Laparoscopic is better for females. Sorry. I probably misspoke on that one. It's in the slides, but say it's just a normal female, okay? And they are very obviously pregnant. We're gonna do an open. Because trying to stick cameras into something with a gravid uterus is most likely going to damage that uterus. So we're not gonna do laparoscopic if they are truly like very, very pregnant. But if it is a normal belly with, it's very, very early in their pregnancy, because, ectopic pregnancies and all that are, could be a cause, we'll do laparoscopic. Sorry if I made that confusing. Anything else? Okay, I will be here all day tomorrow. I do have meetings and stuff, but you have my phone number. Some of you have utilized it to text me. That's fine. Just don't text after like 10. But otherwise, you can text me. If you email me, make sure